The following clinical reflection is based on a case that I attended where a 73-year-old female was experiencing altered levels of consciousness. After the initial neurological assessment and finding that she had slight loss of left-sided motor function, we decided to transport her to hospital in case of a stroke. In the back of the ambulance, my mentor asked me to re-evaluate all her vitals, including an ECG. Everything came back normal, except the ECG reading. It was presenting with varying pulse rates between 40 and 160 beats per minute. I analysed the monitor and every second QRS was normal and every other one had extreme waves that lasted longer than 0.28 seconds, which was exceptionally longer than expected. My mentor's advice was to take a palpitated pulse and disregard the ECG unless the regular alert waves were doing something out of the ordinary. The patient's pulse rate was bradycardic at 56 beats per minute. Once handover was done, I asked my mentor why the ECG was the way it was. I had attended cases where a patient had a pacemaker and the ECG showed varying waveforms, but this patient had standard waveforms and majorly different waveforms in a regular ECG. My mentor explained that our patient had premature ventricular contractions, or PVC. This is what caused the ECG to display a major electrical signal. That due to a single pacemaker in the ventricular section firing off, not in unison with the rest of the heart. This caused a major electrical difference in the ECG, but in reality was not contracting the ventricle and hence not causing a peripheral pulse. At this point, he indicated to me why it is important not to take all advanced technology-assisted information as it is and to conduct my own physical vital signs if something doesn't work or I was unable to get an assisted reading. The following case happened to be an 8-month-old baby with bronchiolitis, which did require auscultations because none of the equipment would fit on him, which supported my mentor's precaution that you can't always take an assisted vital signs. In conducting further investigation into the benefits of automated and manual vital signs, I found that in a study connected to Machalo, Perkins, and Quigley, that automated vital signs majorly improve the time it takes to collect results, by almost 2 minutes as compared to manual vital signs. Automated results would be expected to have faster yields, although the report does also highlight that automated systems are not 100% accurate, and that even further so, that manual vital signs hold greater accuracy as compared to automated vital signs. Considering this, it does highlight in my practice that a manual pulse was more accurate than relying on the automated pulse. The report indicated that blood pressure is one of the essential manual vital signs that needs to be conducted due to the machine's fluctuating results. I investigated into a university study that identified the major benefits and flaws of manual versus automated blood pressures. The Australian report by Heinemann, Selick, and Rickard, etc. all. The main quarrel that this report had was that the automated blood pressure can be inaccurate and may not come back the same results even though the conditions haven't changed. This can affect the patient as it will withhold medication due to hospital protocol. The report was aimed at hospitals and clinics and therefore does not consider the pre-hospital environment in which paramedics work in. Considering that manual blood pressures use auscultation, when considering my practice as a paramedic, automated vital signs are majorly beneficial in 2 ways. The first is that the automated vital signs take less time to complete or can complete themselves whilst running other simultaneous vital signs, drug protocols, or patient histories. Second is that all vital signs aside manual ones such as the blood sugar levels and the temperature are time-stamped, allowing for precise recall of times and values. Although this may be the case for many vital sign surveys, there does exist the opportunity for equipment to fail or for equipment to not display a coherent set of results that confirms the patient's status. This is the point at which a healthcare professional, like I, must ask myself, is a manual vital sign necessary and what possible inaccuracies exist in either manual or automated vital signs? In future practice with situations where the readings seem abnormal or there is a reason to presume inaccurate results, I hope to consider manual vital signs as a reasonable alternative, as there is enough evidence-based practice in hospital and clinical situations that would suggest more accurate results also in the pre-hospital setting, right now in my practice and in my future practice.